Cost is not the goal. This is the disastrous problem we've had in healthcare for the last 20 or 30 years. We've defined a goal of cost reduction. That's the wrong goal. Cost reduction drives you down a path actually to cost escalation. It's a paradox because when you start thinking about cost as your goal rather than value, then you start trying to save money, and you save money by doing dumb things. By doing the things that you have choice over. I mean, in Taiwan, for example, they've beaten down the cost of an office visit really, really low. And they think they're smart. They think they're saving money. But actually what they're doing is they're destroying value. Because the average office visit now is 3 minutes long, and the physician only has time to write a prescription. And so they're ballooning drug cost, and then the patient comes back on average in Taiwan. I think the average Taiwanese patient goes to the doctor like 20 times a year. Because the visit's 3 minutes, and they got to go a bunch of times to get any ideas at all from the physician. So again, we can't think about it as cost reduction. That's the wrong way to think. That's led us down this wrong path over and over and over again. The goal is value. We want to get good outcomes, but we want to do that, hopefully, as efficiently as possible. And as we'll see later, the outcomes and cost are not independent. Those are not two separate things. Those things are connected. And we'll talk about why in a minute. Now, let's look at this value equation. It has a numerator and a denominator. The numerator, outcomes, is very important to understand. Outcomes are results. The patient experience is not an outcome. The patient experience is hopefully something that's good, but the outcome is how well the patient actually does from a health point of view. How well they do in terms of their medical circumstances. As we'll see later, we've got to make a very clear distinction between what processes we use for delivering care and the ultimate outcomes we achieve. There's more than one outcome for every medical condition. We've had a tendency when we do measure outcomes, which is rare, to lock in on things like mortality rates. But we know that for any medical condition, whether it's diabetes or COPD or head and neck cancer, there are multiple outcomes that really reflect how well the patient ultimately did. And we'll talk about that a little bit later. And we've got to learn to measure the whole set of outcomes. And the more we measure the whole set of outcomes, the more empowered we'll be, and the more better equipped we'll be to actually lower cost, paradoxically, as we see later. If you measure outcomes, you actually have the confidence to truly address cost, because you know which costs are not really developing any value for the patient. But by not measuring outcomes, we've had almost religious wars on cost reduction rather than thoughtful discussions about how to actually improve value. The cost side is also very important. When we think about the cost, or the denominator of the value equation, we've got to understand that what we care about is not the cost of any one service. That's not so interesting. It's not irrelevant, but it's not so interesting. What we care about in thinking about value is the total cost of all the services required in dealing with that patient's medical condition over the whole cycle of care. The mistake that so many make in this field is we try to beat down the cost of each service, looked at individually, rather than reduce the total cost of the whole cycle of care. And in doing so, we give up many, many opportunities for investing more in certain things, maybe clinical time in the doctor's office in some cases, in order to save money and avoid having to do other things later on in the process, like have an emergency room visit or have repeated visits over time because the patient ultimately doesn't do as well as we hope. We need to measure outcomes for each medical condition. Measuring global outcomes for an entire hospital is almost useless because it doesn't give us the sense between cause and effect. There's a lot of hospitals, for example, that are measuring infection rates for the entire hospital. That's sort of not that interesting. The infection rate that's interesting is the infection for a particular kind of care. because then we can draw the link between what we do and what the outcome is. If we try to measure these aggregate outcomes for organizations as a whole, we end up obscuring really value, because value is not for a hospital. Value is derived from the care for the patient's particular medical circumstances. And that's been a fundamental mismatch between the unit of organization and the unit of measurement in the past and the actual unit of value. If we measure the outcomes for dealing with COPD and the cost for the whole cycle of care for COPD, then we're in a position to look at value. Then we can compare what outcomes do we get and what's the total cost of getting those outcomes and how could we do it better. This is value-based thinking, and as you can already see, this is quite a very different way of thinking and a very different way of organizing and a very different way of measuring than we historically have done.